Pancreatitis is an inflammation of the pancreas, an organ responsible for producing digestive enzymes and hormones such as insulin. In dogs and cats, pancreatitis ranges from mild and self-limiting to severe, hemorrhagic, and life-threatening. Early recognition and proper management significantly improve outcomes. Dogs typically experience acute pancreatitis. Cats often have chronic, smoldering pancreatitis that develops gradually and may be associated with other diseases. The pancreas is a V-shaped organ located in the cranial abdomen, nestled closely against the greater curvature of the stomach and the duodenum. Because the pancreas lies close to the stomach, duodenum, liver, and bile duct, inflammation often spreads to these neighboring organs.
Physiology, the dual nature of the pancreas. To understand the pathology of pancreatitis or diabetes mellitus, one must first appreciate the physiological elegance of the pancreas. It is, in essence, two distinct organs fused into one anatomical capsule. While it is anatomically singular, histologically and functionally, it operates as a mixed gland, performing two separate but vital roles. The exocrine function, which drives the mechanical and chemical breakdown of food, and the endocrine function, which regulates the body's energy metabolism and glucose homeostasis. These two systems operate in close proximity. The endocrine islets of Langerhans are scattered like islands throughout the sea of exocrine acinar tissue for important paracrine interaction between digestion and metabolism.
The exocrine pancreas, the engine of digestion. The vast majority of the pancreatic mass, approximately 98%, is dedicated to its exocrine function. This tissue consists of clusters of grape-like cells called acini, which are responsible for synthesizing and secreting a potent cocktail of digestive enzymes. These acinar cells are connected to a complex network of ducts that eventually merge into the main pancreatic duct and accessory duct in some species, funneling secretions directly into the duodenum via pancreatic ducts. The primary role of the exocrine pancreas is to neutralize stomach acid and chemically dismantle macronutrients so they can be absorbed across the intestinal wall. This process is mediated by three major categories of enzymes: proteases, amylase, and lipase.
Amylase is the carbohydrate specialist. Specifically, the pancreas secretes alpha amylase, which attacks the glycosidic bonds in complex starches and glycogen. While mechanical digestion, chewing, and some saliva activity start this process, pancreatic amylase does the heavy lifting in the small intestine. It breaks down long polysaccharide chains into simpler sugars like maltose and dextrin. These are further broken down by intestinal brush border enzymes into glucose, which provides the primary fuel source for the animal's cells. In dogs, which have adapted to a diet containing more starch than their wolf ancestors, pancreatic amylase activity is robust, whereas in obligate carnivores like cats, it is present but less adaptable to high carbohydrate loads.
Lipase tackles dietary fats. Fat digestion is uniquely challenging because fats are hydrophobic and do not dissolve in the watery environment of the intestine. Pancreatic lipase works in tandem with bile salts released from the gallbladder. The bile emulsifies large fat globules into smaller droplets, micelles, increasing the surface area. Lipase then latches onto these droplets and hydrolyzes triglycerides into free fatty acids and monoglycerides. Without adequate pancreatic lipase, as seen in exocrine pancreatic insufficiency or EPI, an animal cannot absorb fat. This leads to the classic clinical signs of EPI: weight loss despite a ravenous appetite and voluminous greasy stools, steatorrhea.
Proteases are the enzymes responsible for protein digestion. The pancreas secretes several types, including trypsinogen, chymotrypsinogen, and procarboxypeptidase. However, these enzymes are synthesized and secreted as inactive precursors known as zymogens. If they were created in their active form, they would digest the pancreas itself, the very mechanism that goes wrong in pancreatitis. Instead, they remain inert until they reach the duodenal lumen. Once there, an enzyme on the intestinal brush border called enteropeptidase, or enterokinase, activates trypsinogen into trypsin. Trypsin then activate the other proenzymes. Once active, these proteases strip dietary proteins down into peptides and amino acids, which are essential for muscle repair, enzyme production, and immune function.
The ductal cells of the exocrine pancreas secrete a large volume of bicarbonate-rich aqueous fluid. Its role is absolutely essential for proper digestion and for protecting the upper small intestine. When chyme leaves the stomach, it enters the duodenum with a highly acidic pH, often around pH 1 to 3. This acid, if left unbuffered, would damage and ulcerate the duodenal mucosa, inactivate pancreatic enzymes by altering their tertiary structure, interfere with nutrient absorption, trigger inflammation, or exacerbate conditions like pancreatitis or IBD. The primary function of pancreatic bicarbonate is to rapidly neutralize gastric acid, bringing the luminal pH to an optimal range, pH 6.5 to 7.5. This neutral environment is required for amylase, lipase, proteolytic enzymes to function effectively.
Insulin is produced by the beta cells, which reside in the center of the islets. It is often described as the hormone of abundance, or the fed state. When a dog or cat eats a meal and blood glucose levels rise, beta cells release insulin. Its primary job is to lower blood glucose, but describing it merely as a sugar lowerer underscores its complexity. Insulin acts like a key that unlocks cells, specifically muscle and fat cells, allowing glucose to leave the bloodstream and enter the cell to be used for energy. Beyond glucose transport, insulin is a potent anabolic hormone. It promotes the storage of energy. It encourages the liver to store glucose as glycogen, glycogenesis, stimulates the synthesis of fatty acids, lipogenesis, and prevents the breakdown of muscle protein. Without insulin, as in type 1 diabetes mellitus, the body remains in a starving state regardless of how much food is consumed, leading to hyperglycemia and ketoacidosis.
Glucagon is the counterbalance to insulin, produced by the alpha cells located on the periphery of the islets. It is the hormone of starvation, or the fasting state. When blood glucose levels drop, such as between meals, during intense exercise, or during sleep, glucagon is released. Its target is primarily the liver. Glucagon instructs the liver to release stored energy back into the bloodstream to feed the brain and vital organs. It does this through two mechanisms: glycogenolysis, breaking down stored glycogen into glucose, and gluconeogenesis, creating new glucose from amino acids and other substrates. In this way, glucagon prevents life-threatening hypoglycemia. The health of the patient depends on the delicate seesaw balance between insulin and glucagon. The insulin to glucagon ratio ultimately determines if the body is building up stores or breaking them down. Somatostatin is produced by the delta cells and acts as the great inhibitor. While insulin and glucagon are the accelerator and the brake for glucose, somatostatin is the parking brake for the pancreas itself. It has a regulatory role, inhibiting the secretion of both insulin and glucagon to prevent wild fluctuations in hormone levels. Furthermore, somatostatin slows down digestive processes. It reduces gastric emptying and inhibits the secretion of exocrine enzymes and gastrin. This ensures that nutrients are not flooded into the circulation too quickly, allowing for a steady, controlled absorption rate. Pancreas. Through its exocrine actions, it turns raw food into absorbable fuel, and endocrine actions, it dictates whether that fuel is burned immediately or stored for the future.
The fundamental pathology of pancreatitis is a failure of the organ's safety mechanisms. The pancreas protects itself by storing powerful digestive enzymes as inactive precursors known as zymogens in normal conditions. These are sequestered in zymogen granules and are only intended to activate once they have traveled through the pancreatic duct and entered the neutral pH of the duodenal lumen. In pancreatitis, this safeguard fails, and the enzymes, most notably trypsin, are prematurely activated inside the pancreatic acinar cells. This premature activation triggers a destructive chain reaction, often described as autodigestion. The pancreas effectively begins to digest itself. The activated proteases break down the cellular structure, while lipase destroys the surrounding peripancreatic fat.
Pancreatic pathology. Systemic consequences in pets. The release of massive amounts of inflammatory cytokines into the bloodstream leads to a systemic inflammatory response syndrome, SIRS, and the distension of the organ capsule are responsible for the agonizing pain. This widespread inflammation increases vascular permeability throughout the body, leading to hypotension and shock. Furthermore, the circulating inflammatory factors can damage the vascular endothelium, triggering coagulation cascades that may result in disseminated intravascular coagulation, DIC. When this occurs, the patient is at high risk for multi-organ failure, particularly affecting the kidneys, acute kidney injury, and the lungs, turning a localized gastrointestinal issue into a critical, life-threatening emergency.
The feline variant, Pancreatitis. In cats, the pathophysiology is frequently complicated by their unique anatomy. Unlike dogs, the feline pancreatic duct usually joins the common bile duct before entering the duodenum. This anatomical convergence means that inflammation or infection in the gastrointestinal tract can easily ascend into both the liver and the pancreas simultaneously. Consequently, cats are predisposed to a condition known as pancreatitis, the concurrent inflammation of three organ systems: the pancreas, pancreatitis, the liver/biliary system, cholangitis, cholangiohepatitis, and the small intestine, inflammatory bowel disease. This interconnectedness means that treating feline pancreatitis often requires addressing chronic inflammation in the gut and liver as well.
When it comes to clinical signs, dogs and cats present so differently that they almost feel like two different diseases. In dogs, pancreatitis is usually an acute, dramatic event. The hallmark sign here is vomiting. It is persistent and often severe. You will also see profound abdominal pain. A classic visual clue to look for is the prayer position, where the dog lowers its front end while keeping its hind legs standing up, trying to stretch out that painful abdomen. Beyond the gut, these dogs are systemically ill. They are anorexic, lethargic, dehydrated, and often febrile. In severe, necrotizing cases, they can present in cardiovascular collapse or shock with a distended, fluid-filled abdomen. Cats, on the other hand, are the masters of disguise. Their signs are notoriously subtle and vague, which is why feline pancreatitis is so often underdiagnosed. Unlike dogs, vomiting is not the primary sign in cats. It happens, but it's inconsistent. Instead, the most common clinical finding is simply anorexia combined with severe lethargy. If a cat stops eating and looks flat, pancreatitis should be on your list. Physically, they are often dehydrated, and unlike the feverish dog, cats with severe pancreatitis are prone to hypothermia. You should also check for icterus, yellowing of the gums or sclera, which suggests concurrent biliary involvement or triaditis. In the worst cases, they may present with respiratory distress due to pleural effusion, fluid in the chest.
Diagnostics. When we suspect pancreatitis, we usually start with a minimum database, CBC, KIM, UA. The results here are often messy, but point us in the right direction. You will typically see an inflammatory leukogram, often a neutrophilia with a left shift. On chemistry, don't be surprised to see elevated liver enzymes, ALT, ALP, and bilirubin. The pancreas is angry, and the liver is merely an innocent bystander reacting to the local inflammation. You might also catch azotemia from dehydration or hyperglycemia due to stress or concurrent diabetes. Amylase and lipase. For a long time, these were the go-to tests, but the reality is they are unreliable. They have poor sensitivity and specificity in both dogs and cats. High levels don't confirm pancreatitis, and normal levels don't rule it out.
Diagnostics. We have moved on to better tools, the Spec CPL for dogs and Spec FPL for cats. These tests measure pancreatic lipase immunoreactivity and are highly sensitive and specific. Radiographs are generally nonspecific. You might see a loss of serosal detail, a ground glass appearance, in the right cranial abdomen, but their main value is essentially ruling out a surgical foreign body. The gold standard for diagnosis is ultrasound. An experienced sonographer can visualize the pancreas directly.
We are looking for an enlarged, hypoechoic, dark pancreas, surrounded by hyperechoic, bright white fat. That's the saponification and inflammation. Ultrasound also helps us check for complications like abscesses or biliary obstruction, which changes how we treat the patient.
Next, we have to control the nausea. Antiemetics are essential, not just for comfort, but to allow us to feed the patient. We typically use a multimodal approach. Mirapatant, Cerenia is our workhorse, often combined with ondansetron. If gastroparesis, delayed stomach emptying, is a concern, metoclopramide as a CRI can be very helpful to keep things moving downstream. Finally, let's talk about the biggest paradigm shift in pancreatitis treatment: nutrition. The old school advice was NPO, rest the pancreas by starving the patient. We now know that early enteral feeding, within 24 to 48 hours, actually improves outcomes by maintaining gut barrier health and reducing bacterial translocation. For dogs, we start a low-fat diet as soon as vomiting is controlled. For cats, fat restriction isn't as critical, but caloric intake is. Cats that stop eating are at high risk for hepatic lipidosis, so do not hesitate to place a nasoesophageal or esophagostomy feeding tube early. If the gut works, use it. A quick note on antibiotics. They are not indicated for routine pancreatitis. Pancreatitis is usually sterile inflammation, not an infection. Antibiotics should be reserved strictly for cases where you have evidence of sepsis, severe necrotizing pancreatitis, or suspected GI translocation. Otherwise, you are just upsetting the microbiome further.
Even with the best treatment, pancreatitis can spiral, so we need to be vigilant for complications. In dogs, because the inflammation is often acute and explosive, the complications tend to be life-threatening and systemic. The biggest fear is DIC, disseminated intravascular coagulation, a clotting nightmare where the dog essentially uses up all its clotting factors and starts bleeding spontaneously. We also watch closely for cardiac arrhythmias triggered by inflammatory toxins and acute kidney injury from shock. Long-term, if the damage to the pancreas is severe enough to destroy the islet cells, a dog can recover from pancreatitis only to be left with permanent diabetes mellitus. In cats, the complications reflect the chronic, simmering nature of the disease. The most immediate danger is hepatic lipidosis, fatty liver syndrome, if they refuse to eat for just a few days. Beyond that, we worry about the scarring effects of chronic inflammation. Over time, this fibrosis can lead to exocrine pancreatic insufficiency, EPI, where they can no longer digest food, or diabetes. And remember triaditis. Complications in a cat often involve the liver and intestines, not just the pancreas. Finally, what do we tell the owners about the future? For dogs, the prognosis is generally good for mild cases. They recover and go back to normal life, provided they stick to a low-fat diet. However, for severe hemorrhagic cases, the prognosis is guarded to poor. Survival often depends on how much money and intensive care the owner can commit to. For cats, the conversation is different. Because it is often a chronic condition, I tell owners to expect lifelong management rather than a cure. Their prognosis usually depends less on the pancreas itself and more on the severity of their concurrent diseases, like IBD or liver disease.
So, we've pulled the patient through the crisis. The final piece of the puzzle is preventing a repeat performance. For dogs, the strategy is straightforward. Fat is the enemy. We have to have a tough conversation with the owners about dietary indiscretion. This means absolutely no table scraps, no marrow bones, and no bacon grease on the kibble. For dogs with recurrent acute attacks, a prescription low-fat diet is often a lifelong requirement. Beyond the bowl, we need to manage the dog's waistline. Obesity is a major pro-inflammatory state, and tightly control any underlying endocrine diseases like Cushing's or diabetes that lower the threshold for pancreatitis. For cats, prevention is more complex because it's rarely just about the food. Since feline pancreatitis is often tied to triaditis, prevention means managing the concurrent inflammation in the gut and liver. We focus on controlling their IBD, often with novel protein diets or steroids, and managing any chronic cholangitis. While we still want to maintain a healthy weight, strict low-fat diets are generally not required for cats unless they have high triglycerides. Instead, we prioritize a high-quality, highly digestible, balanced diet that keeps them eating consistently to avoid that dreaded hepatic lipidosis.